Welcome to this BTOG podcast. My name is Tom Newsom-Davis. I'm a medical oncologist at Chelsea and Westminster Hospital in London. I'm also the Vice Chair of the BTOG Steering Committee.
And I'm Leanne Castle, a respiratory physician at Barts Hospital in London.
This is part of our regular podcast series where we have informal chats with experts in their field and tackle the most important issues that we all face in the diagnosis and treatment of thoracic cancers.
It is important to say that the sponsors of BTOG do not have any role whatsoever in the planning, content or delivery of anything discussed in these podcasts. We would love to hear your questions and comments on things we've discussed in this podcast. Please contact us by emailing us at info@btog.org or tweet us at btog.org. Hi Zoe, it's great to have you here with us today, and very timely as I understand it's coming up to 4 years of service for the rehab service in Manchester and nearly 2,000 patients recruited.
Yeah, but in terms of lung, yeah, absolutely.
Brilliant. So Zoe's with us today, and she is the AHP clinical lead for Prehab for Cancer, which is based in Manchester, and she's a specialist OT with extensive experience in neurological and physical rehab. Zoe is also a member of the National Macmillan AHP expert group and has helped produce universal prehab resources in partnership with CR UK. So we're very grateful for her to spending some time with us today, answering all our questions about rehab. Okay, so we'll just kind of dive straight in with the first question. So I think most of our listeners are members of the MDT and they're aware of the role that Prehab plays in the treatment of our patients. But could you talk us through the different aspects that are involved in a Prehab program? Because it's not just all about increasing exercise tolerance, is it?
Absolutely. So so prehabilitation is a range of modalities. The top three that certainly most prehab services would cover is exercise, as you've mentioned, Leanne, and nutrition, and then well-being, so that kind of psychological side of things. However, there are other aspects to think about. So, for example, smoking cessation, alcohol, and other substance misuse, even things like anemia management. So any type of optimization of a patient as they're going through a treatment pathway, where we know that by doing certain interventions, you're going to really optimize their ability to engage in their treatment and to get the best outcomes from their treatment. Within the Prehab for Cancer service, which obviously is what I am involved in Manchester, our main three modalities are exercise, nutrition and well-being. So those are the three modalities we're particularly focused on, but we are very much closely working with other colleagues in terms of some of the other aspects I mentioned.
Thanks very much. And how do you decide who's eligible for treatment? Because you have a huge number of patients coming to our MDTs. How are you picking people out?
So Prehab for Cancer is quite unique because it's a system-wide delivery. So it's we offer it for all patients who live in Greater Manchester, which is a really large area. We've got roughly 2.4 million people who live in this area, and we're very lucky because the service that we provide, we offer it across the whole of Greater Manchester. So how we've been able to kind of target specific groups is we're working with patients who've got either lung, esophagogastric or colorectal cancers. And within those groups, it's mainly focused at the moment on patients who are having surgical treatment. However, specifically in the lung cancer group, we've been able to do some extra innovation around offering service up for patients who are non-surgical patients having other types of treatment, including just recently, we offered up our eligibility to include patients who are diagnosed at stage 3 and stage 4, being offered any kind of active treatment. And once somebody's kind of met the eligibility criteria in terms of where they live and in terms of the type of cancer they've got and what type of treatment they're having, then we've worked very closely with a lot of the clinical teams, a lot of the MDTs across DM, so Greater Manchester, to really talk about which patients would be eligible. And actually, in fact, the majority of patients are eligible. So really, about 90% of the patients coming through would be eligible. The kind of cut-offs that we put in place is it's an adult, so it's anyone aged over 18, but we've got people in their 80s, their 90s, so there's not really a, you know, anybody really over the age of 18. But then also we look at performance status, and we look at the clinical frailty score. So people who have got essentially performance status of 2 or better can be engaging in the service, or people who 5 or above on the clinical frailty scale as well.
And other particular eligibilities in terms of you have to be symptomatic, or are we saying anyone in whom you are planning a radical treatment who has a lung cancer in Greater Manchester should have prehab? If someone's PS0 asymptomatic, are they still theoretically going to benefit from your tender administrations?
Yeah. So how we've done it is essentially anyone diagnosed with the types of cancers that I described, so lung, obviously, which is why we're talking today, but in OG and colorectal as well. Prehab cancer is part of their pathway. So it's the same as really being offered treatment. It's embedded within the clinical pathways. And what we do is we stratify people once they've been referred into the service. So there's an online form that people fill out, because obviously we've got 10 different hospitals who are referring into the service. And then the patients are contacted within a couple of days. They get assessed at their local leisure centre, their local gym. And depending on what the assessment is, basically is about what they're going to get then. So if you've got the person you just described, Tom, who's doing really well, you know, maybe it's somebody who exercises already, or someone who's younger, then that person's probably going to be given what's called a universal programme, where they'll be getting on with things themselves. They'll have some touch points, some contact with our team, and they'll be doing some assessments. But really, they get given a program which they have free access to the leisure centres and the gyms locally to where they live, so they still get that side of things. And we've got lots of resources online, and we've got classes they can dip in and out of, but they don't need as much supervised intervention as people who their functional status is less than that.
So in fact, in your network, you're saying everyone, all curative patients who are being considered for curative treatment because they're PS 0 to 2 should be referred to you. I mean, that's a huge difference to what's happening in my neck of the woods, where no one's referred unless you think they're not actually going to be able to get to treatment. I don't know if it's different in your neck of the woods, Leanne, but we don't do that at all.
So we're keen on referring kind of more of our patients, although I would probably say that I think because of the pressure on the service, maybe the kind of PS0, it's more, we probably don't sort of worry about it so much, but otherwise anyone else we kind of is pushed through. But I was quite intrigued by what you were saying about using the leisure centres, which is obviously a great idea. So I mean, I'm sure everyone's got a leisure centre reasonably close to them, but when they go to the leisure centre, are they actually being seen by the leisure centre staff to kind of assess their exercise capacity rather than kind of NHS based staff? So
the staffing model we have is basically what I will say was we're very lucky in Greater Manchester. So we've got what's called GM Active, which is all the leisure providers in GM have come together under one banner, and we've worked through them throughout the whole of the kind of design and delivery of this. It's very much a collaboration, and all the staff involved are all cancer rehab qualified. So they've all done extra training. A lot of them have worked on pulmonary rehab. A lot of them have worked in falls prevention, cardiac rehab. And so they've all got quite a high level of qualifications. And then we actually have a core prehab for cancer team. So that team, so it's commissioned by the NHS. It's an NHS team essentially, but they're all exercise specialists who work in that team. They've got myself, I'm an OT by background, so I'm the AHP clinical lead, and then we've got John Moore, he's our medical clinical lead. He's an anaesthetist by background, and what we do is we do quite a lot of upskilling with them, and we do a lot of continued professional development sessions. We did I don't know if you're aware of the stepped care model, which is a psychology model about how much support patients might need from a psychology perspective. And all of the people who work in the programme have all done level 1 on that, which is about being able to provide some level of wellbeing support to patients. So we've done a lot of training with those staff members. And we've got 90 leisure centres where we can deliver this in. The assessment clinics are in basically there's 1 or 2 leisure centres in each locality where we do it, but once a person's been through that assessment and we know what they need, then they can essentially access the programme in the leisure centre that's 2 minutes from where they live. And that's a big part of the success for us, because partly we just knew that if we asked people to come to the hospitals to do the prehab, that would be a barrier. But the other thing is that this isn't just about optimising someone for treatment. This is about lifetime behaviour change as well. And we do, as well as having the prehab phase, we have continued interventions if somebody's having non-surgical treatments, so during their kind of radiotherapy, chemotherapy, immunotherapy. But then afterwards, everyone gets 12 weeks of rehab when they're back at the leisure centres, in the gyms, depending again on their needs, back working with our team. And then we're very much thinking about how we kind of try and promote that independent, confident exercise once somebody's been discharged from the service. And actually, we've done a lot of follow-ups of patients who've been through the service previously, and we find that people are still exercising and still doing incredibly well.
Are there any contraindications to this? Are there any people who really can't? I mean, obviously, someone doesn't want to come, they don't have to. But are there any physiological, clinical, social factors which would lead you to say, do you know what, this isn't for you?
So the only thing that would be really a contraindication is about any potential safety issues or harm that would befall somebody engaging in the community prehab and rehab service. So, for example, if somebody's got specific cardiac issues, if we've got people with aneurysms. So there you're
going to be sending them up towards a cardiologist before they head to the leisure centre. Yeah,
absolutely. And things like, bone mets, if somebody's got the risk of spinal cord compression. We work very closely with all the MDTs and all the allied health professionals and nurses across Greater Manchester. So the very kind of top tier of patients that can't access service, which is a very small percentage, it would be thinking, well, what else could they access? So what else support could they get? But you'd be surprised, the majority of the patients who are referred through to us, we are able to work with. And we have the ability to work with people remotely and in person as well. So.
Okay, so you kind of have these kind of hub leisure centres where people can be first seen, and then they can be seen at the smaller leisure centres. But also there is the ability for them to do like virtual online sessions as well. Okay, that's really interesting, isn't it?
Yeah, we did. That was a COVID forced on us by COVID, really. But actually, it's been really helpful, especially for patients who might be shielding in advance to surgery, or who might be a little bit reticent about being in community spaces. When they're going through specific treatments. So it's helpful that we can continue to do those interventions with people.
Yeah, I think the kind of interaction with the community via the leisure centres is really quite innovative, and it's also really quite helpful for the patients too, isn't it? Now, once they're like in the programme and they're doing their rehab, how do you reassess them to see if the rehab's helping or if it's working? Yeah.
So we assess people at 4 time points through their pathway. So baseline when they're first referred, which is normally within a week of when they've had their cancer diagnosis. Then we assess them again pre-treatment. Now, obviously, if somebody's going on to kind of immunotherapy, chemotherapy or radiotherapy, then we try to do another assessment kind of in the middle of treatment. But for surgery, it's really obvious, we've got the baseline and then the pre-surgery assessment. We then reassess somebody after they've had their treatment, so after they've had their surgery. And actually, there's a big focus for us on patients who are having adjuvant treatments and about how we really engage them. And then we do our final assessment at discharge. So we're able to really track people and see what improvements they're making. And what we're finding is that from a functional perspective and a physiological perspective, people really do hugely improve during that prehab phase just before they start their treatment. And again, the improvements that we see when somebody's discharged from the service from their baseline are often quite big as well, which is part of the reason why we've been able to get recurrent funding and been able to keep the service going for the last 4 years.
And do you use like a standardised measure to assess that, like their 6-minute walk distance, or like kind of the reps they can do maybe, or Yeah.
So we did used to use the incremental shuttle walk test for lung, because obviously that's kind of mostly recognised for lung. But because the 6-minute walks used universally, to try and make our data much cleaner, we use the 6-minute walk test for all the patients. Yeah. We use the 6 minutes, 6-minute walk, and then we use the sit to stand in terms of strength. And we also do grip strength as well. We do a whole plethora of quality of life and functional assessments. So we do things like the EQ5D, the EORTC, QLQ, CL30, the HUDAS. So all these different outcome measures that are more about people's functional ability and about their quality of life and their well-being. And then we also we do the self-efficacy scale for exercise, because we understand that part of that assessment is how confident somebody is to actually engage and how activated they are, and understanding, again, going back to that behaviour change aspect.
So do you think, I mean, with those long lists of quality of life questionnaires, I mean, that you guys are the absolute experts, you have huge proficiency. Is there going to be a problem trying to roll out this model outside of Manchester if we're expecting so much data to be collected, or are you doing those EQ5D, etc., more from a research point of view to prove the system works?
So it's a mixture of two, if I'm honest. Partly we had so many outcome measures when we first started because we were a transformational programme and we needed to really demonstrate the value of what we were doing. But there really is a lot in the interventional side of doing those assessments, because it really does help patients to understand where they're up to in terms of you know, what's happening for them. Just going through some of those questions can be really light bulb moments for patients in terms of what their needs are, and where they might be doing really well, or where they might need you know, further signposting, etc., certainly in terms of quality of life. And for example, with the nutrition side of things, we do what's called the PGSGA, which is a nutritional screen. And when we first started, what we realized was that most patients don't have any kind of nutritional screen. If they do, it might be a day or two before their surgery as part of their pre-op. And obviously you've got a very small amount of time then to do any kind of intervention or any improvement in terms of someone nutritionally. So what we found is that by just introducing that nutritional screen, and we've got a RAG system of being able to flag patients back to the clinical teams if they are shown to be nutritionally compromised in any way, we've been able to massively improve people's nutritional status without actually really doing much more intervention within the programme. So we do give advice around nutrition, but for example, we haven't been able to give supplements or anything yet. That's something that we're working on. But what our data shows, that even just doing the screen and then flagging that back to the clinical team with 3 or 4 weeks to go before somebody's treatment, it's enough time then to actually really make a difference in someone nutritionally. So the screening tools, I know they seem arduous. We've been going now for quite a while, so we've got it down. They're very quick. We can send them out on email. People can do them online, or depending on what needs people have, or they do it with the Prehab for Cancer instructors. And it's an hour session, essentially, the assessment clinic, and it helps the Prehab for Cancer instructors really provide personalised care, because they get to really understand the patient, understand what's happening for them, and the programme they prescribe for patients is very personalised to individuals. So, which again, I think is part of the success of the programme.
And people who are listening might think, you know, oh, this is very labour intensive, you know, what's the point in doing all of this? But there is evidence, isn't there, that this type of prehab improves patient outcomes. Yeah,
so absolutely. So there's evidence in the literature and the research. Certainly there's been systematic reviews within lung, which absolutely shows there's evidence. But anecdotally within our service, and we had an independent service evaluation completed by a commissioning support unit after a few years, and the outcomes were phenomenal. We've shown huge reduction in healthcare resource use. We've shown improvement in survival at 1 year. We've shown improved physiological outcomes. People less time in hospital, less time in critical care beds. So in terms of
shorter post-operative stays, and
absolutely. So in terms of, because what we're talking about really is about recovery, essentially, about how we're trying to improve somebody's recovery, and our independent evaluation, which is available for anybody who wants to have a look at it, it really does demonstrate the value. I think we've shown that the return on investment is about 3 or 4 times over what it costs to pay for the service. And so in terms of that, I appreciate it might seem quite laboursome, but we really do think it makes a huge difference. Well, we don't think it, we know it, because we see it with I was going to say, we've had over 3,000 patients now accessing the service. So yes, we really do have a lot of data and anecdotal qualitative data to support what we're doing as well.
So there's lots of things changing in lung cancer pathway, and rather good timing that we've just found out that neoadjuvant chemoimmunotherapy has just been approved by NICE. It's going to, I think, fundamentally change the pathway for lots and lots of patients who've currently, we are doing surgery and then we're giving adjuvant chemo to. I think a lot of these guys are going to get neoadjuvant treatment. Is that a challenge? Is that an opportunity for you? Because you're not going to have that treatment-free period because people like me are going to be throwing chemoimmuno around. How are you going to adjust your excellent scheme? Are people on chemoimmuno going to be going to the leisure centre still for their prehab?
So as I've described before, we've been working with patients who are having those types of treatments for the last few years anyway, and they've been done really well engaging the service. As a comparison, our OG pathway, because they offer neoadjuvant chemotherapy, from the day one, from April 2019, we've had OG patients who've had a similar pathway to what might be happening within lung going forwards. And although the feasibility is something that we're very aware of, understanding the ability for people to engage when they're going through that kind of treatment, we have made it work, and we have found that we're still making improvements in people's functional status, their physiological status, even after they've been through their neoadjuvant period and they're coming up to their surgery. We're still seeing that we've improved their physiological status from where we did their baseline prior to them having their chemotherapy or immunotherapy, which is phenomenal, really, if you think about what that kind of treatment does to a person. To actually be able to maintain and improve somebody physiologically, I think it's really testament to why it's really important to continue doing prehab despite having that challenge. So it's a fantastic opportunity. I think the key thing really is the feasibility bit, and it's about understanding that you really have to monitor patients very carefully. You've got to really supervise people who are doing any kind of interventions, and it's the logistics of how you fit it around someone's treatments. But then again, having remote offers, having the ability to get people onto virtual classes, all of that really helps to kind of navigate those challenges that might come up.
And on a similar theme, and you touched on this at the beginning, presumably if you can do it for neoadjuvant patients, you can do it for patients with stage 4 disease. I mean, why? Those are the patients who perhaps need prehabilitation more than anyone else. And it sounds like that there's no particular barrier from your point of view, but I guess it may be in terms of resources, because can you really do this for everyone, or do you have the resources to do it for everyone? Because those are big numbers.
So we've recently had extra funding awarded to us to again, innovation to work with stage 3 and 4 cancer patients, lung patients who are having any kind of active treatments. So now in Greater Manchester, if you're a lung cancer patient and you are being offered active treatment, you will be able to be referred into prehab. We are mindful that there is certain considerations that's different to our other cohorts. So, for example, we've got increased psychological support for the staff who are delivering the service, bearing in mind that we're working with a group of people that have got a completely different prognosis to the ones who are coming in under the curative pathways. And also we've got increased dietetic input, because again, we think that nutrition is going to be really important for this group. But yeah, absolutely. The kind of the focus is a little bit different. It's not necessarily thinking about, we are trying to extend people's life, and we are trying to certainly improve somebody's quality of life, which is really the whole aim of the service. So the focus is slightly different, but we're very excited about the work we're doing with those stage 3-4 patients who are coming.
And will that stage 4 work, is that kind of in alliance with your palliative care teams, or is it actually very separate to that? Is this a separate cohort?
It's in alliance with the palliative care teams.
Okay.
So we've got all the CNSs across GM. We've done a lot of work with them. We've done a webinar for them on this new group of patients we're working with, and we've got a lot of them involved in the kind of design and delivery of this, and then also the kind of palliative care teams within the communities. What we're very conscious about is that people will be deteriorating potentially quite quickly, and obviously one of the things that happens with our team is that we might be seeing a patient 2 or 3 times a week, where they might not be seen by their clinical team just because of the nature of the way the NHS works, maybe for not as frequently. So we've done a lot of work in terms of our protocols about red flags and what to observe, when to get back in touch with the kind of clinical teams and the named referrer, and being able to have that really good communication, so that if patients are deteriorating, We know at what point somebody's not necessarily going to still be able to benefit from engaging in the service.
It's a very extensive service that you're running. I guess
Thank you.
just to take like a little step back. There's always some patients that we can't engage with, and I think in your colleague's tweet he was talking about kind of up to 80% engagement, but in that kind of 20% or so that that you can't get a hold of. Do you feel that there's any particular reason why those people don't want to engage? Have you identified anything that that we maybe can think about in clinic and target? Yeah.
So some of it's really silly. So some of it's things like we've not got a good mobile number for somebody, or we've not got the right contact details, which that's just classic in the NHS, isn't it? Some of it's about understanding and education of patients. So I think what we've really focused on, and we've had a lot of engagement from all the clinical teams, is in fact, we've spent a lot of time talking to patients. Before we even started, we had a patient focus group of about 25 people, and we said, how are we going to make this work? How, what would you need to do to convince you to do this? And as an OT, it makes me want to cry a little bit, but what they said was, if the oncologist tells us to do it, or if the surgeon tells us to do it, then we'll do it. And so that's the really key thing. I think it's about understanding that this can't be just an added extra over here that somebody gets a leaflet for. It has to be that it's embedded within the pathway. It has to be that the MDT are considering somebody's eligibility for prehab. They're having conversations with the patient along the same time. They're having those conversations about cancer diagnosis, about what treatment options they've got. They're really advocating to the patient how important it is and how much of a difference it's going to make. So I think that's part of that 20% of people not engaging.
They've got to do it as well, have we? So basically, yeah, the doctors have to tell them, and then also, I guess, then it's CNSs when they're seeing them as well, and just kind of reinforcing that. I mean, I know it probably goes back a bit to that old classic. I always tell our patients that they won't get their operation if they're still smoking, that the surgeon will be very cross and he won't do it. Yeah. So maybe that kind of that kind of carrot approach. But do you ever identify other things? So I know, so I live in a major city too, where there's very good public transport, but the patients always hate to travel. They constantly, even going 2 miles is too far, which, I'm sure some of our colleagues who work in rural areas must kind of really roll their eyes at. But are things like that barriers sometimes? Do you find the kind of transport or support, is it to do with support?
So,
is that why patients don't want to engage?
So we knew that transport would be a potential barrier, which is why we've designed the service the way we have in the community and the leisure centres. So really, no one would need to ever travel more than 30 minutes to access the service. If that, normally the service is within a mile of their residential postcode. We've really gone to town on making sure that transport wouldn't be an issue. I think the other thing that is an issue, which I didn't raise previously, is just the timing of it all. So what we sometimes find is that somebody might get referred, and then something changes and they go straight into surgery, and we've just missed the opportunity to get them involved. So that's often another reason why somebody might not have been able to engage. And that actually really does account for quite a high proportion of the patients that haven't been able to engage. I mean, I think there's other things. I mean, a lot of the work we want to do going forwards is that targeting inequalities and being aware of all the different protected groups and, ethnic communities, etc. We're just conscious that it's how you engage different people from different backgrounds, and even just the barrier of walking into a leisure centre. If somebody's never exercised before, if the last time they walked into a gym was 20 or 30 years ago, it's how you really encourage people to do that. But to give you just a comparison, if you look at things like pulmonary rehab, if you look at other rehab schemes, I think engagement levels are like 50-60%. So I think we're very happy with our engagement levels. We appreciate we could do better, but I think that we're really confident, and because we've been able to maintain that even during COVID, we're able to maintain those engagement levels. So I think the engagement is really high, but I think there's a lot that we could do collectively within an MDT to try and make it even higher.
Just out of interest, is it all based in, so it was quite interesting you said about maybe some ethnicities or some groups of people are not used to going to the gym, and that seems really, there's too many young people in lycra, or something. Absolutely. Like that. Do you have any sessions that are kind of hospital or even community clinic based, so for those kind of maybe those gym adverse people, because the other incentive is I'm sure lots of people, you know, free classes at the gym, that probably gets them there, but there are those people who probably, it's just, if you're maybe in your early 80s, it's a bit of a shocker, isn't it, sometimes going somewhere like that. So do you have any clinical based sessions now, or is it all in the gym? Yeah, in Manchester.
So what we have got a little bit of InReach. So we've actually started to, we've got the one-stop clinic that we're doing within our respiratory centre, and we have a Prehab for Cancer exercise specialist based within that to try and work with any patients where they might be harder to reach. Some of the sessions are done in community centres because it really is about what's available within each locality. One of the nice things working with the leisure organisations is that they normally know their communities really well. So if there is any barriers that might come up, they normally help us to overcome those. But like I said, what we do is once that person's been to an assessment clinic, which most people come along to that, if they kind of say at that point, oh, do you know, I really don't want to go to the gym, it's really not for me, then that's when we're saying, well, we can do this remotely, you can do home exercises, we can be on the phone to you, we can be on a video call. We give out heart rate monitors, which are digital, that we can actually monitor remotely. So for example, if when we do our exercise classes online, our instructors can, if everyone's wearing a heart rate monitor, they can actually monitor how the intensity of exercise people are doing. So we've got lots of different bits and pieces in place to try and make sure this isn't one size fits all. It really is kind of personalised to the individuals being referred in.
It's very impressive. I don't know whether this is related to Manchester Mayor, but it seems to be
he is a big proponent. He's a big fan of us.
Manchester seems to be winning on getting their funding into the community. Yeah.
The King of the North, Andy Burnham, he has been, I mean, he knows a lot about the service, and he's come along to various events that we've run, so it's really good. I mean, he's really into his exercises, isn't he? So yeah, it's good to have people like Andy involved.
Yeah, that's how you got your funding. Yeah, okay. And then
I was just going to ask one question about, we talked a little bit about barriers, and don't want to revisit it too much, but I was just thinking, as you discussed describing people who may go, often one of the concerns about, I guess, what might be seen as these elective services is that the uptake is lowest in the lowest socioeconomic group and highest in the highest socioeconomic group. Have you seen that? And have you looked for that data?
We're looking at that data now, if I'm honest, actually. One of the kind of feedback with our independent valuation was that we did definitely need to do more about understanding the different groups who are coming through. I think we'd spent so much time at the beginning just trying to get it up and running, and we were getting high numbers of referrals, so we were kind of just rolling with it. But now what we're really doing is digging more into the data. I mean, in Greater Manchester, it's a real mixed bag in terms of affluence. You know, we've got some really deprived communities, especially in the north part of the city, so yeah. So again, I think we're lucky because we're working in those community environments that are within those places. So I think in some ways that does help to overcome the barrier for those patients, but I still think there's probably more we could be doing around those groups. But again, like I said before, I really think it comes back to the message that comes from the clinical teams when patients are being seen, when they're being diagnosed, and it's amazing how much that kind of discussion really galvanizes people, and it's really that teachable moment. What we have found is we did try and get people into the service earlier than when they'd had that final diagnosis, and that didn't work at all. It really didn't. When people had the symptoms and were going through a diagnostic pathway but not a certainty around a diagnosis, they really weren't in a position to engage. So that's one of the big learnings.
That's very interesting. Yeah.
Brilliant, Zoe. And just kind of to cap off, we've talked a lot about lung cancer, but you look at you looking at other cancer groups as well within Manchester, kind of coming along to your programs as well?
Yeah, so esophagogastric and colorectal cancer patients are already part of our service eligibility and have been since we started, along with lung. But what we're looking now, what we're calling it Prehab for all. So it's how we take what we've done for those specific groups and we extend that to all cancer patients across Greater Manchester. And so we're looking at various options around that. digital options, a real stratified approach to how you get people in. Some of the groups we're particularly focusing on, again, is where the evidence lies. So some of the kind of major surgical groups, gynae, gynae-onc, HPB, liver, urology, etc. But really what we recognise, and there's a big push from our Cancer Alliance, who's essentially the people who funded us in the beginning and who've been a big support of this, is it's how we offer prehab and rehab for all cancer patients, but basically very much recognising not everyone needs the same thing. Going back to Tom's previous point about if you've got patients who are doing really well, who are not asymptomatic, who are, the performance status is good, they're not going to need the same thing as somebody who's not in that position. So it's really about how we tailor the service. I think what we've recognised is that the assessment is the really key part. So if we can get an assessment for everybody, then we'd be able to really prescribe what individuals need, and we'd be able to kind of probably stratify the resource as well.
Fantastic. It's been really great hearing all about your service. And just to kind of sign us off at the end, so I think that probably my take-home point is that I have to tell everyone that they should all really go to prehab, and it's really important for them, whatever treatment they're having. But what would you say the other kind of take-home messages for the people
listening
along are? I presume the kind of personalised treatment is really important, but
yeah. I mean, what I would say is that there's so many people nationally and internationally who are trying to make prehab happen now, and there's so many fantastic resources. So I'm very conscious that we're in a very privileged position where we are, that this is on offer for people, but there is loads of resources available online. We've got our Prehab for Cancer website, which has got loads of videos, but there's Macmillan have got lots of stuff like CRUK, etc. So I suppose the take-home point I would want to say is that all MDTs should be talking to patients at diagnosis about prehabilitation and optimization. If they don't have a service to be able to refer someone in, they can signpost people to lots of resources that exist. And it really does need to be personalized, like you say. So one of the things that's really key is about understanding individual patients. I think there's that fear that if you say go and do some exercise, depending on what's going on for somebody, they could cause themselves some harm. But 9 times out of 10, actually, it's going to make a massive impact on them if they do find a way of engaging in prehab interventions. So those would be some of the key points from me.
Brilliant. Thank you so much for talking to us.
Thank you for listening. We hope you enjoyed this podcast. For more information on BTOG, including educational events and how to join, of course, you can visit www.btog.org. Just to remind you, we would love to hear your comments, thoughts, questions about things we discussed, and for the really interesting ones, we'll even discuss them in our next podcast. You can contact us on info@btog.org or on Twitter @btog.org. Thank you very much.